and welcome back. I'm back again to introduce the speakers in our next session, which is all centred around the user prosthesis interface. This session consists of two 25-minute talks, each of which will be followed by a 5-minute question and answer session. Our first speaker is Kia. Dr. Kia Nazarpour is a reader in biomedical artificial intelligence at the University of Edinburgh. Kia's research interests relate to neural systems and rehabilitation engineering and machine learning for health. And today he will be discussing the case for and against pattern recognition for myoelectric control. Welcome and thank you, Kia.
Thank you very much. I hope you would be able to hear me. So I'm going to share my screen by saying continue. Right, you should be able to see my screen now. Perfect. Thank you very much. So yes, I was going to talk about the case for and against myoelectric control, but then it's an interesting kind of times in the UK in terms of collection of evidence for the use of prosthetics. So whilst I thank the organizers for inviting me and asking to talk about pattern recognition, I'm going to sort of talk a bit more kind of wider aspects of prosthesis, upper limb prosthesis control, and how it is possible to create evidence. I'll try to cover those aspects in terms of pattern recognition as well. Okay, so I want to focus on the topic of beyond the laboratory prosthetics research, and I talk about an Internet of Things platform that enables collection of evidence. I've been told that there are a lot of people in the audience who might not know about the how myoelectric control myoelectric prostheses are controlled, and that's a kind of a very simple diagram. So when the decision about movement or movement intention takes place in the brain, the signals travel down the spinal cord and manifest on the stump. These signals are recorded by surface 2 or more surface EMG electrodes, and then we send these signals via a pipeline to a decision maker, and where we can, upon training of the system, we can distinguish or we can predict the user's movement intention. For instance, if the user wants to grasp with a power grip or do a pointer. And that decision is transferred into a prosthesis, and some prostheses provide sensory feedback to the nervous system. So here's a kind of a general block diagram for the control. Now, in academic research for the past 60 years or 50 years, people have been trying to use a machine learning approach, the so-called pattern recognition, to try to improve the function of these devices. What typically happens is that many safe sensors, many EMG signals from the stump are recorded, and they go to a block, which is, we call it feature extraction. And there's some functions are applied to these signals, and some signatures for each movement is extracted from the data. And these signals then go into a block, our machine learning or our decoder block, like a neural network, recently some deep learning algorithms, and then that decision is mapped onto a prosthesis, and the prosthesis is actuated. So this is a kind of an interesting concept, because it is very intuitive. People can imagine a movement and actuate their muscles, and the machine would be able to predict the exact labels. And based on that, there has been some commercialization as well. For instance, Co-opt in Chicago, they have come up with a system. There are other companies as well have worked in the area, and they have their own versions of pattern recognition. Touch Bionics had it many years ago, and Orthotics as well. But they are not really widely used in the in the clinical system, in the clinical services at the moment. Now, instead, in the clinic, what we have is that we usually kind of record from two channels on the flexor and extensor group. And kind of a similar but hardware-based feature extraction happens. Two signatures from the signals are extracted, and then simply a table is formed. If both of these two muscles are below their respective thresholds, nothing happens on the hand. Hand closes if only one muscle is activated, or hand opens if the other muscle is activated. And if both muscles are active, something else happens, a grip selection happens, or a wrist rotates. Now, this has been remarkably stable for the past, I don't know, about 100 years, not necessarily myoelectric control, but even body-powered prostheses work exactly the same way. And here are some examples. This is a video that was provided to me by Alex Shadwell in Salford, and she shows how the reality of myoelectric control in a clinical setting, in a two-channel system that in this video, a person wants to grab this object, the cylinder, grab this cylinder and put it in a tube. And you can see how difficult it is, despite the simplicity of the control, actuation of the device with this controller. Now, I'm going to show you what pattern recognition can achieve. So with only two sensors, high quality sensors on the forearm, although selected between many of the sensors on the forearm, we can achieve this level of control in the laboratory. So in real time, a person would be able to control 4 or 5 grasps, 4 grasp and opening of the hand very smoothly and reliably. So one would ask why, if this level of dexterity can be achieved in the laboratory, why this is not available in a clinical sector widely. So there are a plethora of reasons behind that. I start with the clinic. We heard earlier, about 20 minutes ago, that time is an asset, is the perhaps most significant and most costly item in a clinic. Current clinical teams would not have to play with these algorithms to kind of find the right balance in terms of function and generalization. So on top of that, staff training is always very difficult. Typically, the customer service that is provided by some of the facilities manufacturers are either poor or they are very time consuming, because currently, for instance, in the UK, the device has to go to the clinic, and then from the clinic to the manufacturer sorts things out, and then go back to the clinic and then to the user. So, and I think most importantly, we suffer from a lack of evidence whether these devices, these multifunctional myoelectric hands, controlled with pattern recognition or any other controller for that matter, actually improve the quality of life of people. So on the user side, there are so many variables that affect and degrade the quality of control. Limb position, orientation of the limb, especially in the case of long transradial amputations or limb difference, and also adaptation of the behavior by the user. Essentially, people start behaving and showing muscle patterns that they did not manifest in a clinical space during calibration of the device. So our systems are in the terms of machine. These algorithms do not typically adapt, although there are claims out there for this automated adaptation. We don't see much evidence there. We have lack of after-use training of the data, and therefore frequent recalibration are required. And by nature, we don't really see generalization to unseen grips and on pattern. By intrinsically, it is limited. So in a laboratory, most of the research that have been doing so far are based on offline machine learning or offline pattern recognition. that we know that they do not generalize in real-time experiments when a user is in the loop. Results of studies with able-bodied experiment do not generalize to studies with people with limb difference. So therefore, it's a bit of a challenge there that most of the pattern recognition studies that happen at the university or academic sector are based on with able-bodied people, and they do not generalize to people with limb difference. And finally, therefore, all of the upper limb prosthesis control experiment with machine learning should be done in real-time setting with people with limb difference. So if you go down like that, and that's kind of very difficult for the current research in the UK and internationally, people on short-term contracts and PhD students being able to kind of develop these settings to work in real time with people with limb difference. It's a bit asked from early career researchers. So what we kind of came up with the idea that would be able to kind of run this experiment instead of in the home, instead of in the laboratory, in the home environment. So we have a prosthesis user that wears a device and is controlling the muscle data, controls the device, and the muscle data goes through a Wi-Fi sort of cloud system, goes to an IoT portal, and then it goes to a server where machine learning and all of the aspect of the control and reporting, visualizations, app, and everything happens. And then we would be able to kind of link with the clinician and be able to provide kind of reports about the use of the prosthesis in almost real time for the user. We designed two apps for the clinician as well as for the user, where the user would be able to kind of see what happens in a prosthesis in exact real time. We report on the kind of the function of the device. We enable the device to be recalibrated or not. The user has the option of stream the data into the portal when they want or they wish, and they would also be able to kind of tag the device by providing feedback, general feedback about the function of the device, or general in terms of the comfort of the device and the function of the device, so that we would be able to see contextualized data from the in terms of the data, the raw data, as well as the user feedback and comfort of the device. Also, with the user feedback dashboard, we would be able to see when things don't go in the way that the prosthesis a user wants. They would be able to report and provide us with correct labels for the data that we just recorded. So here's an example of the air control, a simple controller. It's a two-channel controller, and the data is generated by the user. It goes to our kind of the abstract control, which is a human-centered version of for prosthesis control. The data goes into the controller, the device is actuated, and then the user would be able to, what we can do is to look at endpoints of where the kind of user landed in the controller space, find out where all the blue ones are correct decisions by the machine, and then the red ones are where the machine made a decision, but that was not the decision that the user wanted, and the user kind of labeled them as incorrect decision. And this data and this label goes to our backend machine learning or pattern recognition algorithm, and the decision boundaries between different classes can be updated. So here's an example of how prosthesis control with pattern recognition can take place, with pattern recognition or without pattern recognition, can take place remotely. So it does not require a kind of a direct operation of a clinician to adjust the parameters. So here's a video of that we kind of recorded during the COVID pandemic. This is an able-bodied participant in a lab controlling a prosthesis with our abstract control system. Note that the screen is where the data goes on the internet and on Wi-Fi. So the data physically leaves the device the control kind of and the reporting and streaming happens on the internet, although the control of the device happens on site. As you see, the user has a mobile phone, and during that period of actually using the device, should they wish, they would be able to provide feedback about the device. If everything is worked, the label for the device is, there's no problem in terms of control. So here's another example of halfway in a trial, something goes wrong. So the person wants to do a tripod grip, but a pointer happens. They provide the pointer, and then if you saw, they click on the mobile phone to provide a correct label for the device, for that trial. So currently the NHS policy for the UK NHS policy for clinical commissioning of these devices is out for consultation, and currently the patient pathway is very complex, and it's hoped that by the provision of this, by updating these patient pathways, the upper limb prosthesis will be prescribed in NHS. But we are kind of interested in kind of a new care model. And this is what we have been thinking. So at the moment, when a limb loss happens, either in case of amputation or controlled amputation or otherwise, the person goes several times to a clinic, and they have to kind of wait for a long time, and then they pay another visit, and then wait another long time. They receive a socket and a prosthesis, a body-powered controller before a myoelectric control, and then many kind of months or years after that, they might kind of provide, you might go to the clinic 1 or 2 more times to fine-tune something. And this is a very passive way that this care model is provided. So what we are kind of interested is providing the users with a virtual clinician in their home environment. So before the fitting, when they go to the clinic, they receive a device, they can train their muscles by the use of serious games, and then the clinicians will be able to manage their expectations. And this continues. They go several times to the clinic, they receive a prosthesis or a socket, and then they continue this bilateral and bidirectional relationship rather than a user going simply to the clinic. And we hope that after fitting with this and with the use of these virtual clinicians, we would be able to improve adherence to the device and improve the adoption of or retention of these devices, as well as enable remote recalibration and firmware updates, as well as kind of automated reporting of these devices. So this approach of this beyond the laboratory or beyond the clinic prosthesis research requires a large amount of co-creation between various stakeholders, from the ideation of this kind of starting point until the implementation and evaluation of these services. And we've been aware of that. So most recently, and during past 6 months, we've conducted 2 workshops in Edinburgh, and during these 2 workshops, where we had many stakeholders, about 40 stakeholders, coming together and working together what it means to conduct research or clinical trials in people's home environment, outside the clinic or outside a research laboratory. So how it is possible to share data, what type of data people would be happy to share, and how they'd like to share, how often they like to share, and how it is possible to work towards creating evidence in line with what the NHS would require. So here are some quotes from users who took part in our co-creations. One said, "I'm happy for my information to be on a central database. Not only it is helping me, but it is also helping future amputees as well. All the pros and cons of these devices, things I can do, things I cannot do, and things I'm struggling with. It would be good to kind of report them and document them." And another user of prosthesis users said that, "I think it's a fantastic idea to have a more environmentally contextualized assessment, because device usage does not happen in a vacuum, it happens in a context. And the elements within that context can make it easier for very much more difficult cases, depending on the context of the use. We are hoping to submit this this document is a long document reporting the two workshops, hopefully before Christmas. So if anyone would be interested to kind of having a look and exchanging ideas, please feel free to drop me a line. So closing remarks. So I think the key two take-home messages are verifying innovations in prosthetic research quantitatively cannot be done in laboratory setting or in 10 minutes clinical testing. It needs to be done on a long-term basis in people's home, work, real-life environments, where more realistic constraints are imposed on pattern recognition or even direct control or other controllers or our abstract controllers. And there are more realistic conditions. And it also enables us to create user level or use level standards and metrics, which should be clearly of interest to clinicians and policymakers, as well as manufacturers and insurance companies. But Alex provided this figure to me, and she showed that many years ago that it is possible to kind of monitor these devices outside the laboratory on a long-term basis. But the reality is that if that monitoring does not lead to real-time changes in the control of the prosthesis, they might not affect the way that they might not affect the rate of retention in these devices. So we hope that by this remote monitoring, we would be able to have better assistive technologies in the long term, and we would be able to nudge better use by collaborating with diverse stakeholders. We would perhaps be able to create evidence that shows the enhanced quality of life for users. And from a scientific point of view, we would be able to create new tools that enable studying sensory motor neuroscience in a totally different context. And from a machine learning and artificial intelligence point of view, it's a true platform for a human-in-the-loop AI in the wild setting, which are not many of them are around from in the myoelectric in the machine learning community. So the work that you saw was collaboration of several people over years, including Matthew Dyson, Linda Webb, Hangjing Wu, Hannah Jones, and Agamemnon Krasoulis, and some of them are still with the lab. Some, like Matthew, has already set up their own laboratories in other universities. Matthew is now based in Newcastle, and he has his own research team. So thank you very much. That is the end of my talk, and I'm happy to take any questions that you might have.
Thank you very much, Keir. That was really, really interesting. I have a few questions that have come through, but first off, I'll just satisfy my own curiosity. So you say that the data collection that's been conducted previously using offline machine learning and using able-bodied people is not necessarily representative of the true outcomes found when you start to use people with a limb difference. Why is it that they've historically been employed?
I did not catch the last part of the question.
Oh, sorry.
Why
is it that they've historically been used? Why is it that they've gone for like offline machine learning and able-bodied people?
The answer is very easy, because it is easy to download a database from internet and apply some myoelectric control and publish. Unfortunately, the rate of publication of offline data is massive. And now the real-time data are coming out from various laboratories. There's a clear evidence that offline data with able-bodied people have nothing to do with real-time use of prosthesis.
Great, thank you very much. We've had a few more questions come through. So Liam has asked, would you support provision of multiple limbs or terminal devices depending on activity? Or do you think one limb should be able to do everything? And would this help retention and use of the limb?
So I think when you talk to users, to the users that I have talked to, they prefer these activity-dependent devices, and you see the noise, I think, from behind me. Children are very excited. Yes, so I support you having activity-dependent the prosthesis, but that doesn't mean that the myoelectric prosthesis should not be able to provide the function that people require. I can't hear you.
Sorry, typical, isn't it? We also have a question from Sean, and Sean has asked, are all patients with upper limb loss suitable for pattern recognition technology? And is it possible, or is there a need to apply this technology in the case of the lower limb?
And the case for the use of pattern recognition for lower limb is a lot more stronger than the case of upper limb, simply in terms of number of degrees of freedom that you have in upper limb. I'd like to kind of draw your attention to the fact that the use of pattern recognition for upper limb has been around, or the proposal has been around for the past 40 years. And yet there's only 1 or 2 companies that claim to have the solution, which is not popular at the moment. Or the market has been very limited due to many factors, perhaps including the price. So I am a lot more supportive of the use of pattern recognition for lower limb than in upper limb.
Sorry, that's very interesting. Thank you. I have one final question for you, which is from Balint, and that is, can virtual simulated devices play a role in a system like this, or are they too different from real hardware?
Very interesting question. We have just got a paper out with the title, Why Serious Games Are Not Serious Enough for Myoelectric Control. So the evidence is very sketchy there. The use of serious games, virtual environments, simulators, there are clear evidence that they enhance the engagement of the users with the device initially. They help with building muscle activity, and a take-up of the muscle, take-up of a prosthesis initially. What is lacking at the moment is evidence that suggests the use of this virtual reality or simulator, in fact, improves the control of these myoelectric devices. So perfect in terms of engagement, no evidence whatsoever so far that they, or very rare evidence that they improve the control of this device, that they transfer to the device.
Okay, that's great. Thank you very much.